Today, we are so excited to welcome rural physicians Dr. Davis Yani and Dr. Firdaus Mydeen for an engaging session on the impact that rural preceptorship can have on both communities and the next generation of rural physicians. Dr. Firdaus Mydeen is a family physician in Westlock and the Associate Clinical Professor at the University of Alberta. Dr. Mydeen is redefining rural medicine and the role of AI in healthcare from his early days practicing in Westlock to his current role as Zone Clinical Department Head for Rural Medicine. He has built a career marked by innovation, leadership, and a deep commitment to mentoring future physicians. He also leads the PNME, Preclinical Networked Medical Education Program at the U of A, inspiring the next generation of clinicians to pursue careers in rural practice. Recognized with both the Preceptor of the Year Award for teaching medical students and the Teaching Excellence Award for training family medicine residents, Dr. Mydeen continues to shape the future of healthcare through education, advocacy, and digital transformation. Dr. Davis Yani is a UCLIC, University of Calgary Longitudinal Integrated Clerkship Preceptor, and has proudly served the community of Taber for the past 11 years as a family physician. He is an enthusiastic supporter of rural medical education and plans grassroots multidisciplinary medical education for his colleagues in Taber, such as More OB, Teacher and Breakfast Educational Rounds, Taber, and Pre-Med Club, among others. He lives in the village of Sterling with his wife Eliza and their 4 children. I will now turn things over to both Doctors Mydeen and Yani to get us started.
Good morning, everybody. Thanks for making time for this session. Power of the preceptor and how preceptorship drives recruitment to rural communities. And I'll just skip to my first slide. And I would like to thank RhPAP to give me the opportunity to have this chat with all of you. So I think all of you are familiar with the problem in rural. We have recruitment challenges in different aspects of things, but we also have some strengths. The problem is we have, physician/provider shortages and high turnover. Limited training exposure at times for some of the providers, so they might not feel comfortable being in what we call halo settings, which is high equity, low occurrence. So sometimes you have just simple things showing up in emerge, and then you have pipe through the chest, for example, or massive MI with cardiogenic shock, stuff like that. So not everybody would be comfortable dealing with these things at times. There's misconceptions about rural practice as well. There's a variety of settings that we can create, and we can have a really meaningful practice depending on what you want to design in rural. It doesn't have to be a single dimensional type of practice that some people might think is the way to practice. Also in rural, we have reduced access to care. That's a big problem that we are trying to solve by recruiting more preceptors who can train future doctors who hopefully eventually join us in rural to solve that problem. The solutions, these are not all of the solutions, but potential solutions, is to have structured mentoring relationships with learners, have authentic rural immersion, having them to come to rural town to actually see what we do and how we live, I think improves that attraction, but also to change their mindset that rural actually can be a flourishing setting for future doctors. And we're trying to not just, have doctors to be trained. We want all of the healthcare teams to see the same as well. So we team up with the other departments, nursing, allied health, to come and experience the same thing as well. And our RhPAP has expanded their roles from physician to others as well, which is helpful. Community integration is key as well for a solution. We were just chatting before the session started that if a healthcare provider lives in town versus commuting, there's a difference in how that integration translates into investment in the community as a healthcare team. Our RhPAP support and resources has been big for us to continue to do what we do. This session is one of them, and there's many others that they do. Skills Day, for example, where they bring busloads of learners to experience rural practice and to practice some skills as well. Why preceptorship works, positive rural exposure. So early experience is the #1 predictor of rural practice, and that's been shown by data, both from the PNME and ICC data that we know about. And then building a sense of belonging, create social connection, sense of place before graduation. That tends to change the trajectory and also the mindset of future healthcare workers. And dispelling the myths, challenges the stereotypes through direct experience, showing them what they may have heard that could be misconceptions. We can correct them when they come and actually share a few hours or a day or two with us, even longer for some of the other structured experiences, such as the LCE, PNME programs, where first and second year students come and spend more than a day with us. For PNME, they spend a month. And of course, for ICC program, which is a integrated community clerkship program, they spend about 10 months in a community in rural. The impact, this is my personal experience. I've trained more than 100 learners, LCE, first and second year students, third year students with ICC, PNME students, elective students, which tends to be fourth year medical students, dozens of second year family medicine residents. I do assessment for the college as well. And I also entertain pre-med students who are interested in healthcare, and they come and hang out for part of the day. Some data, when these learners slash healthcare residency and assessment docs come in, they're 2 to 3 times more likely to practice rurally. 85% report increased interest. This is RhPAP data from 2022. And having trained these many learners, it's very rewarding to see quite a few of them coming to rural to help us out to solve the problems that we mentioned earlier. Early preceptor is recruitment, and it is a recruiter. Your mentorship shapes career decisions for these young minds. Your community becomes their community when you actually share that with them. You can only read so much about Tabor and Westlock, but when you actually come and see and how you can live here and have family and community around you, it makes a big difference. Your passion inspires the next generation. And I would like to thank you all for considering to be a molder of future minds who may become our future rural colleagues. Thank you.
Excellent. Thank you so much, Dr. Mydeen.
You're
Dr.
welcome.
Yanni, if you're ready, we'll turn things over to you.
Thank you very much, Anya, for that introduction, and Emily for inviting me to do this. And thank you, Dr. Mydeen's excellent presentation. Wonderful to listen to you. I work in Tabor. I have lived here for 11 years, been a family physician here. I teach UCLIC students primarily. It's my main gig. I have had about 8 UCLIC students, counting the one I'm teaching right now. And so those are really long-term relationships. You spend about a year with those students. I also do elective students. I've had shadowing students, high school students, pre-medicine students come in and work with me. I am going to be a teacher at the SAMP medical program. And we also have residents come through here, and I will participate in with my colleagues in teaching the residents. So I've had a lot of teaching experience. I love teaching. I've been doing it for years. And this was a really enjoyable exercise getting ready to give this presentation, because I asked myself a question: why do I teach? And the only answer I can give you is because someone once taught me. And teaching is such a unique and impactful relationship. The preceptor-student relationship is like none other. You go through so many things together. You go through difficulties together. You experience incredible growth together. And there's nothing quite like that. It's such an honor to be involved in it. And I wanted to just share some anecdotes from my own personal experience of being trained, and share how these anecdotes inspire me as a teacher now. Um, Pardon me. So if you could pull up the map, Anya, I was hoping, are you able to screen share? Oh, thanks, Emily. Yeah, so I painted this just to show all the places that my wife and my kids and I moved to during residency training. So we started out down in Lethbridge in the southern part of the province. And our first site in family medicine residency was Stettler. Some of you might recognize the Big Valley Railway there. My son loved seeing the train come in every day. Eliza would take him on her lap, and they'd head down to see the train arrive from Big Valley every day. So that's a very meaningful remembrance for us. My preceptor there was Alistair Drummond, who I'm sure many of you had the privilege of knowing. He's no longer with us. He shared so many pearls of wisdom. I love the way he taught me in his office. And he was a Scotsman, and of course it was, very easy to listen to his voice, that beautiful Scottish accent. And he would pull me aside after, an interesting clinical encounter, and he'd say, now, Davis, as you know yourself, and then give me some clinical pearl. And I love the way he taught, saying, as you know yourself, because he made you feel like you were really, a part of the team and you really knew something, even though I didn't know anything. So Alistair did a great job of just putting you at ease and making you feel part of the team as he taught you. And he also was extremely generous. They had the Eddie course, the one of the first iterations of POCUS, and now it has different names, but Emergency Department Ultrasound course. They brought it in for the physicians in the town, and he asked me, "So you're going to come to the Eddie course, right?" I said, "Well, that's $1,200. I can't go." And he said, "Of course you're coming, and I'm paying for you." So he was so generous. He paid for me to do this training course and learn emergency department ultrasound. And I I think maybe I would have learned emergency department ultrasound on my own later, but maybe I wouldn't have. And his act of generosity has cascaded many, many, many events, including, finding an aortic dissection and a cardiac tamponade and a ruptured ectopic, which are all diagnoses that were really, really challenging to make before emergency department ultrasound. And so, there's literally lives saved because of his investment. And so when we invest in our students, when we give of our time, we are investing in our collective future. And now, you know, dozens of students of mine learn the skills of emergency department ultrasound because of the generosity of one Alistair Drummond.
Thank you.
So one other site that we were posted to is Whitehorse, way up north in the Yukon Territory. And Cindy Breitkreutz and Stephanie Buchanan were my preceptors there. They were so generous with their time. They made us feel so welcome in their territory. And I got to go to fly or travel in clinics with both of them into very remote and northern settings. They invited our family to their cabins. We went kayaking with them out in Teslin Lake and Marsh Lake. We had so many wonderful memories. It's just an absolutely precious time and set of memories for me and my family. Those relationships were very close at one point. And the interesting thing about this preceptor-student relationship is for a very brief time, you were like intensely connected. You talk a lot. You sometimes stay up all night together, working in the emergency room, seeing patients. Like it's a strangely close relationship that you build. And I mean, I remember with Stephanie Buchanan managing labors in the middle of the night and, dealing with persistent anterior cervical lips and, heart rhythms, fetal heart rhythms that were made you nervous and just, things that really bond you because you went through them together. You endured that anxiety of not knowing what's going to happen and how are we going to get this patient through this. In fact, I mean, I've been on call all night long, taking care of a patient with congenital long QT syndrome, who had a very abnormal heart rhythm in a child, and with my Euclid preceptor at my side, and we just ground out a nighttime call shift. And these are like defining moments. These are moments that you actually will remember, and they shape you for the rest of your life. And then those relationships end, and sometimes you don't see your students or hear from them for years and years. And I think it's really neat that you have these intense, close relationships, and you remember and are molded by the experiences you have. But life being what it is, we can't always keep up with everybody. But I'll share one interesting thing about these two preceptors from the Yukon. So Cindy Brightcrowes, uh, she was a mountain climber. She loved going into the mountains, and we got invited to dinner at her house once. Got to see all of her pictures of climbing Mount Steele and skiing on glaciers way up in the Kluane in the high mountains of the Yukon. So I knew that she was a mountain enthusiast, which I shared with her. That's something I love too. And I was hiking with my kids in Waterton, which is what, 2,000 miles away from the Yukon. And we were just nearing the summit of Carthew Alderson Pass. And I saw this person that looked oddly familiar coming down the mountain towards us. And as she got closer, I thought, I know that person. And then I heard her voice. And I may not be very good with names, I'm terrible with faces. But when I heard the voice, it was like, Cindy Brightcrowes, and I went out for the big hug, the big sweaty, I'm climbing this mountain hug. And Cindy was kind of terrified at first because she had no idea who I was until she heard me say my name. And then we had a great little catch up and talking about old times in Whitehorse. And those relationships, as I say, they're so special. And you carry them with you for the rest of your life, the way that you've been shaped and molded by your preceptors. I have one last anecdote. In Raymond, which is the town I actually grew up in, I also worked as a resident, and I worked with these three doctors there: Clayne Steed, Terry Smith, and Wally Tallstrip, and wonderful preceptors. These were sort of like stalwarts of the community. They'd served for 4 decades as sometimes the only physicians in this small community. And once I admitted a patient, Winona, who was an elderly lady, and she had pneumonia. I took care of her pneumonia, gave her antibiotics, and put her on some IV fluids. And I came back the next morning to do rounds, and much to my shock and dismay, my patient was in congestive heart failure. So she was crackles all through her chest, and she was obtunded and really, really struggling to breathe. And I was absolutely devastated because this was obviously something that I had done. I had put her on IV fluids, not realizing how vulnerable she was to heart failure, and had completely fluid overloaded her. And I still can vividly remember going into the ER break room there in the Raymond Hospital and just being completely emotionally devastated and just weeping, not knowing what's going to happen and what do I do? And one of these preceptors, Terry Smith, came in. And he wasn't upset, he wasn't angry, he wasn't correcting me, and he knew I knew what had happened. And all he did was give me a big hug and showed care and compassion. And we got Winona on Lasix, and she recovered to the extent that she could. I mean, she was very ill at that time. And Winona had some nice time with her family before she passed. Um, with an interesting anecdote, Winona was actually my old neighbor, so I grew up in this town, right? And I had shoveled her walks and like taken bread over for my mom, and checked on her as a widow for many, many years. So her family invited me to be a pallbearer at her funeral. So a very full circle moment. Um, and mostly what I remember that experience is the graciousness of patients and families who understand that we are human, and as physicians, we make mistakes, and sometimes we don't get everything right, and sometimes things go wrong. And the graciousness of my preceptor at the time, who, when I was in a very vulnerable moment, thinking that just terrible about myself, I was just greeted with compassion. And in Tabor now, where I work as a preceptor, I hope that each of my students who, they move on, they go out into the world, they make their own success and their own future. I hope that they carry a little piece of their experiences here with me, to every patient encounter that they have, that I can be that voice that, encourages them to dig a little deeper into their differential diagnosis, or to encourage them to set aside judgment and prejudice, and to really be present for a patient and listen to what they're saying, and to be that voice that encourages them to be compassionate to themselves when something's gone wrong. Maybe they didn't do the very best they could, but to take a step back and realize that they were trying, and that they were doing what they could for the patient. And I hope that I'm the voice that just encourages them, that keeps them going when their career gets difficult, and that also they can feel that voice of celebration, knowing that when they have success, whether I know about it or not, it's bringing me happiness and joy. So yeah, my talk is all about the relationship between preceptor and student. I teach because someone taught me, and I'm always grateful for the experiences that I had, and for the graciousness and kindness and compassion of my preceptors, and for their medical expertise as well. But I I hope that each of you who are listening today might feel inspired to be a preceptor, um, for the sheer joy of seeing someone learn the things that you've worked so hard to build skills and to acquire, and for the joy of knowing that when you become a patient, there's going to be somebody ready to take care of you.
What initially inspired you to become a preceptor? And did you have a mentor in the past who influenced your career path?
Yes, I had a lot of mentors, and that's the reason why I'm doing what I'm doing. And I am very lucky to have passed through their experiences and their encouragement to do rural. I trained in Malaysia initially, and then I came to Halifax. I got my MD from Dalhousie. So that's where my first rural experience started, in Dalhousie, where I got placed in Woodstock, New Brunswick, a small town of a few thousand people. Excellent preceptor who actually, yeah, just opened my eyes that it's a wonderful setting that you can have your practice in, but it's also good for you and your family. So um, Dr. Goodine was one of my first mentors, I would say. And then I, of course, got in touch with my rural preceptor at the U of A, who Dr. Hendricks in Wetaskiwin, who again inspired me, and Dr. Jill Conkin, who's not with us anymore. She's a big inspiration. She drove up to Westlock in 2012 to recruit me to be a preceptor. So she's a big one, with Dr. Peter Hamilton, who came up with her at that time, and miss her terribly. She has done a huge impact for many of us in this call and throughout the country. She also helped to set up NOSM. So those are a few names I would like to share. Thank you.
Amazing. I think it's so impactful when you are able to share forward what was shared with you as a learner, and then as a pivotal person in the community. I have a question for both of you, and so maybe I'll throw it to Dr. Yanni first. How do you create an environment where learners feel supported and confident to ask questions or make mistakes? Because I'm sure that happens occasionally.
A fantastic question. I think the beginning of that is with the orientation process. So I do try and make a point of reaching out right away as soon as I have the email address of a student who's coming out here, just to open the line of communication. And that's a signal that, you know, we're here for you and we want to talk to you. We're excited to have you. And it's just rolling out the welcome mat. And then when they for Euclid preceptors, we have like the incredible benefit of having an orientation weekend where we all get together, preceptors and students. Obviously, not every rotation will have that sort of opportunity, but still, just the way you welcome somebody into your office, the way that you welcome them into your practice, and help them orient. And you at some point have to just convince them, whether they believe it or not, that you're not there solely to write their ITER. You're not there solely to give them a place to work, or you're not there solely to create a labor for them, but you're there to shape them and mold them and to help them become the best physician that they can be. And I make it very clear with every student that my one goal for you as a student is that you will become a generalist, that you will develop foundational skills. And that doesn't mean that you have to become a family doctor or that you have to work in a place where, like where I work. But I just want every student to have foundational skills, to be able to turn their hand to whatever comes their way in their medical career. And that's what generalism is. It's the ability to meet the moment that you have to, that comes to you. It means being flexible in your expectations and being able to always remain patient-centered, and be there for what comes your way. It means community service is like a pillar of why you do what you do. So those are the tenets that I just, that I insist students adopt here. And that's my one goal, is I'm trying to shape you into that. And I make that expectation clear. And I think when mentorship or when orientation goes well, then the students know exactly why you're doing what you're doing, and they don't question your motives.
Excellent. Dr. Mydeen, do you have anything that you'd like to add to that in terms of how you help your learners feel supported and confident to ask questions and make mistakes?
Absolutely. I agree with Dr. Yanni. First of all, orientation is key. Create that safe environment that they can ask anything. Anybody is capable of culpability. It's just how you navigate that. We've created a very safe sandbox in the clinic and hospital, with each learner with the capacity. So it's a safe environment. People can make mistakes, but we have a way to navigate through that and mitigate that in the first place.
Excellent. So it looks like we had a question pop up in the Q&A, and Dr. Yanni has his mute off, so you're up first by default. What are some of the challenges that come with being a preceptor, and what advice do you have on overcoming these challenges? Are there ways for communities to support preceptors in their teaching? And maybe that's a two-part question. So we'll start with the first one. What are some of the challenges that come with being a preceptor, and what advice do you have for overcoming those challenges?
That's a great question. I think the biggest take-home message I would say is you can't do this alone. You need help. So in Tabor, we set up clusters of preceptors who are the primary preceptors. We all teach, so it really helps if you and your colleagues can be a cohesive unit in working together to create that supportive learning environment. And I would say I'm kind of like the lead orienter welcomer, but then I send my students off to others. And, on the residency side, I have other colleagues who do the orientation and who welcome the residents in. So we kind of specialize a little bit. We organize it so that we each have specific roles, and then we have clusters of preceptors. So the student isn't always with one preceptor. I think that really helps. It spreads the burden, because having a student it's not always easy. It's an added cognitive burden in the clinic. You have to teach, you have to be mindful of them, you have to be thinking of more things than you think of when you're just on your own. So it's really good to spread that out. And I think that's good for the student because they just need to see multiple perspectives, multiple ways of practicing medicine, and everybody has a different unique style, and they can take pearls from each one of us. So it just works better that way. So that would be my advice: is it's all a teamwork and some specialization in terms of orientation and welcoming.
Excellent. Dr. Mydeen, what would you have to add to that? What challenges come with being a preceptor, and what advice do you have for overcoming those challenges?
So having a community of preceptors connecting with each other, and like Dr. Yanni said, when the students spend time with different preceptors, having different perspectives, I think those are important because what works for one preceptor might not be the same for the others, and the students have to see that, oh, I don't have to exactly practice like Dr. Mydeen. I can actually do what Dr. Yanni does, and other options. So I think having that networking between preceptors, sharing students in other, practices and other physicians, other preceptors, enriches the experience so they know there's options, not just one single way to do things in rural.
Absolutely, sharing the load. I know today we're joined by several of our community members with the attraction and retention committees. So the second part of that first question was, are there ways for communities to support preceptors in their teaching? And maybe Dr. Mydeen, I'll let you start with that one. What can communities be doing to support physicians like yourself?
Sorry, what the community does to support what we
Yes,
do?
how can the
Okay.
communities and the attraction and retention committee support you as a preceptor?
Yeah, we have a robust committee in town in Westlock. So we actually have an event where we bring students up and trying to recruit them. So how it works is that we foster a healthy relationship between the town and county and surrounding areas with our hospital leadership and community healthcare leadership. Because we are all here for the same reason. We want to bring more healthcare workers to town and hopefully get them to stay in town so they're part of the fabric of the rural community. So I think bridging the leadership is the key, I would say, and we got robust support in that aspect.
Excellent. Dr. Yanni, do you have anything to add to that in terms of what communities can be doing to support the work that you're doing as a preceptor?
Mhm. The best example I've ever seen is in Sundre, and I'm sad to say I can't roll out Tabor as an example. And Tabor's a very welcoming place, but we're not organized. Sundre is organized, and it sounds like in Westlock, the key is having a attraction, retention, recruitment committee, which partners between the MD or the county, the town, the hamlets and surrounding villages. That's the key, is to get all those stakeholders to be talking with one another and everybody contributing in some way to attraction, retention, and recruitment. So we're in the infancy stage in Tabor. I'm looking to other communities though to learn because I know we can do better at that.
Wonderful. Moving forward, we have another question here, so we'll start with Dr. Yanni. What strategies, in addition to great preceptorship, do you believe could effectively strengthen the rural health workforce pipeline to support and sustain continuity of care? So what strategies do you believe would strengthen the workforce pipeline?
It's a really good question. So I'll tell you what we're doing in Tabor for that. So we, in partnership with the Cooley Medical Clinic, we're doing a pre-medicine club. So that's also in partnership with the Horizon School Division. So we are meeting at least a few times every fall and a couple times every spring, bringing in high school age students and university age students, like pre-medicine students, who are by and large connected to Horizon School Division still by their, that's where they graduated from. And we're giving them an opportunity to, for instance, we did a question and answer panel with, kind of talking about how do you prepare for medical school, and a big proportion of students have this idea that there's one way to prepare for medical school, and you must go down this path. And it was really, really helpful to have my current students come to that Q&A and just open their eyes to there's so many different career paths that can lead you into medicine. So that's a big misunderstanding that young students have. Another thing that we're doing in the pre-medicine club is like hospital tours and simulations where we, practice using ultrasound or working with a simulation medical mannequin, for example, and doing CPR. So we've done things like that. Another thing that I've been doing with a team from Tabor is an EPIC career conference. This is run by a program called Career Transitions. It's located in Lethbridge every April. So for one day in April, I go with a team of other healthcare providers, and we volunteer our time to basically help inspire the pipeline by running, again, usually a simulation. We did a birth simulation, which was very exciting for those grade 9 students. I don't know if we recruited as much as we turned away with that simulation, but the last year we did a cardiac arrest simulation. So I was the patient who was experiencing chest pain, and then I arrested, and we turned our attention to the mannequin, and we got these grade 9 students doing CPR, and I'm running around coaching them, and it was really a lot of fun. So I hope that we're encouraging the pipeline. We're doing things like that. We also, my wife and I and my colleagues here have started the Tabor Clinic Scholarship, where the Tabor Clinic is contributing $2,500 scholarships for several students every year from the Horizon School Division who are interested in careers within health sciences. So we've given that scholarship to people who are going into nursing school, people who are going to pre-medicine, people who have all kinds of career aspirations. And, this is it's definitely early investments. You start very early on in this process. I hope that all of these efforts will, in 5 or 10 years, bring us lots and lots of doctors and nurses.
Amazing. Such great initiatives that you're speaking to. Dr. Mydeen, do you have anything to add in terms of what strategies you believe would effectively strengthen the rural health workforce pipeline?
Yeah, so I agree with Dr. Yanni, got to start early. So high school engagement is big. I also been lucky to be part of a project that we started, FOMAC, which is Future of Medicine Art Contest. So we get high schoolers in whole of Alberta, only rural. That's a tricky definition to navigate, but we got that done with the company that we assigned to get it done. So basically, they have to submit an art submission to visualize or imagine how healthcare would look like in their community in 20 years. And the winner gets $1,000. So we've been running that for a few years. And the winner also gets a shadowing opportunity with the rural doc. So that's one of the opportunities that we've been part of.
Amazing work you're both doing in your communities. Another question that has come in, and I'll put it over to Dr. Mydeen first. As a preceptor, do you only mentor students and residents, or do you also teach foreign-trained physicians who are already here in Canada?
So yeah, I do give a shadowing opportunity for our internationally trained physicians, but I also do assessment for the college. So they're IMGs who are going to integrate in the rural communities. I've been doing that since 2012.
Ashamed to say I haven't waded into those waters. I feel tempted, but I just am so comfortable with my earlier stage students and enjoy working with them so much. I haven't taken that on. I've thought about the opportunity to do a PRA, because I know for these communities who are needing those physicians, like they really, really, really need that person. It's such an important bridge, that last step to get an IMG over the finish line and practicing independently in Canada. So it's incredibly important work, and I'm grateful Dr. Mydeen is doing it. And very thankful for my colleagues in Brooks who have done it for us here in Tabor.
We have a question in the chat that I think everyone would like to hear your thoughts on. How can we encourage more rural family physicians to share their expertise and knowledge and see preceptorship as more than just extra work. I know you have very busy practices and family lives, so many things going on. How do you encourage others to fit it into their life and encourage them to pursue preceptorship?
That's a really, really good question. I have some success stories. So, start with your friends. They, there's something about recruiting friends. It's a little easier. You can just talk more freely with your friends. You can be open, so easily with your friends. And that's very much what I've attempted to do today, and sharing very personal stories. So I think, I mean, there's lots of ways that preceptorship can be incentivized, and truly RhPAP is like an incredible supporter. DLRI at the University of Calgary is an incredible supporter, in financial ways, in ways of supporting students and facilitating students travel, facilitating students housing. I mean, these supports are unprecedented, and they've made a huge, huge difference to rural preceptorship. And I'm so thankful for them because, had it not been for those supports, I probably wouldn't have had the opportunity myself to be trained rural. And I probably wouldn't be a rural family physician were it not for these sorts of big financial supports from RhPAP and DLRI. So those are huge. But ultimately, on an individual level, I think that people choose to be preceptors, not just because of those supports, but because of a desire to share what they've been given. And if you can, share your own stories with colleagues, talk about those things, have be open to sharing why you're inspired to teach and what it does for you, because it's that, in giving back, you always receive more. Like you end up on the giving end of that relationship as a preceptor, but really you're still just enriching your own practice by having someone that you're sharing these really incredible moments with, of growth, of hardship, of joy, of witnessing humanity in medicine. And I think that's something that keeps me going and will inspire other people to take up the torch and become preceptors themselves.
Incredible. Dr. Mydeen, would you like to
Thanks.
add to that? How could we
Yeah,
encourage more family physicians to share their expertise and consider preceptorship?
of course. Yeah. Thanks, Dr. Yanni. I agree with Dr. Yanni. And well, the big thing is teaching sounds like it's another task. And we have rural workforce that's already burnt out, overworked, and we need help. But teaching is actually silver lining. I joined the PNME program with Dr. Conkin during peak Delta wave of COVID pandemic. People thought I was crazy to add that to the amount of work that we have to do. We were the respiratory hub for the area, so anybody's on up to 6 liters of oxygen gets sent to Westlock, and we had a bed crunch. And then I took up this, teaching position. But actually, the teaching position empowered me and gave me hope, infused me with positive energy, and we had to navigate the pandemic and place these students in rural sites and continue to support them. It's the opposite. It's counterintuitive. It's the antidote to the very stressful moment we all had to go through. So sharing these things, it's very counterintuitive, that teaching looks like an extra task, but it's actually very, very rewarding, and it actually can save you and give you more energy to what you do. Because these young minds, they infuse energy to your environments. And, I see gout and I'm like, okay, gout, just treat it as usual, versus my students saying, I just saw my first gout case, and, you can see the glow in their eyes. I'm like, wow, that's great. You get reinvigorated in our field. So just to give you an example.
Amazing. That sort of leads into another question that we had come in. Are you seeing the same themes in students in your preceptorships that originally attracted you to becoming a physician? Is that inspiration being tapped into, or are there ways to tap into the inspiration and support it more? Dr. Yanni, if you'd like to start.
Yeah, I do see similarities in students. I think many students who come here, they are wanting the opportunity to be a part of the team. They are coming from, a place where, call it, assembly line manufacturing of medical students. You can feel lost in a big school with 180 classmates. And here you get a personal stamp put on you, where you find yourself starting to sound like your preceptor, starting to use the same phraseology as your preceptor, because you spend so much time together, working together, listening to them, educate patients, and you're molded and shaped, and you grow to be like your mentor. And so it's kind of a unique learning experience. And I think that's what I was seeking for at that stage of my career. I was seeking for like the ability to become a little bit more independent, to see lots and lots of undifferentiated patients, and that's what students now want when they come out here.
Absolutely. Dr. Mydeen, what do you have to say in terms of themes in students in your preceptorships, how they compare to what originally attracted you to becoming a physician?
Yeah, I would say clinical courage. Like Dr. Yanni was saying, undifferentiated patients. So getting them to examine patients earlier on under our supervision and breaking that mold, as a learner and grow. And that is the most important characteristics, I would say, that I'm looking, because the way things are getting trained in med school now is going more towards digital, but I still, even though, AI is here and taking us somewhere else, we should still stay grounded and do a lot of hands-on clinical experiences. I think that's key. And telling them you're going to be a doctor, you're being molded into one, so you got to start acting like a doctor now, not next year, not until fourth year. You got to start that mentality now. That framework has to be adjusted, and I think that is crucial to build that network of students who becomes us eventually.
Absolutely. And when you were speaking, it reminded me a little of parenting. I think we've all been there when we've heard our parents' words come out of our mouths to our children, and you take pause and realize how much that's been ingrained in you. I have one last question for both of you, and that is, how has mentoring students and residents changed you as a practitioner? We've talked a fair amount about as individuals, but as a practitioner, how do you find preceptorship adding to the work that you do for your community? Dr. Mydeen, if you'd like to start.
Sure, yeah. So it's a bit more work, but we have to remind ourselves that this is a work that hopefully is going to pay itself off by bringing more colleagues to the community, and then the work will lessen. And I've already seen that change in my own practice, that we have more doctors in town. So that's the way you invest in your future. It takes time, and it's important to look after yourself, because burnout is real, but burnout should not be the poster child of our profession. We need to look after ourselves. We need to have mechanisms to look after ourselves. Otherwise, it's hard to look after others. And we need to share that with our learners. And if you look after yourself, you spend about 10-15% of your time doing something fun, something engaging, something that grows the next generation. The return on investment is huge.
And Dr. Yanni, how do you feel mentorship and preceptorship has changed you as a practitioner?
That's an interesting question. It's hard to recognize you being changed. And this has been an excellent exercise for that reason. I would say it, as Dr. Mydeen has already mentioned, it keeps everything fresh. It keeps, the ordinary, mundane things of practice interesting, because you're looking at it from new eyes perspective. So it gives you that constantly renewed perspective into medicine. It keeps that awe and wonder alive, and it keeps you honest because you have to be on your best behavior. You're modeling what it is to be a physician. And so when you catch yourself maybe cutting corners or letting prejudices creep into your decision making, you have to check yourself more frequently. And it also provides you lots of opportunities to be humble, because sometimes your students will recognize things that you miss. And your students will challenge you sometimes when you've become unconsciously competent, or perhaps even unconsciously incompetent. And your students will sometimes say, well, actually, this is the way we're taught now. And so you get a chance to go back and refresh your knowledge and constantly be renewed, be challenged to be the best version of yourself. And that's what I like about teaching.
Wonderful. Well, thank you both so much. I'm keeping an eye on the time, but want to sincerely thank you for your candor and your expertise and the inspirational stories that you shared today. I think hopefully you changed the minds of a few that are listening, and preceptorship absolutely will continue to support rural medicine. Again, thank you both so much for sharing your thoughts and your candor and your experience with us today. I thoroughly enjoyed listening to you. I think we could all continue to listening to you, but I know that you have very busy lives and practices and preceptoring to get back to you.